computer.
Ah, good.
Well, somehow you turned on the auto captioning and it's closed captioning now.
I see that. I'm trying to disable it, but I don't see where we do that. Oh my goodness. Nope. I got it.
File. No,
Okay.
you got it.
Yeah,
Excellent.
yep. Sorry about that. We'll just start right from the beginning here. So first of all, welcome to everyone, especially those who are visiting. This is the Connecticut Medical Advisory Council's September 30th meeting. We have 2 more fall meetings. We'll talk about those a little bit later. But I'm going to jump right in and remind you that, as you know from my earlier struggles, we are on Zoom and we are recording this meeting so that those who could not attend in person will be able to view it on demand when we share the YouTube link. I'd like to pause for a minute and thank our meeting sponsor tonight, and that is Gilead. So Andy Lovejoy is with us. So thank you so much, Andy, for your support of the American Liver Foundation. We always appreciate you being with us.
You're so welcome.
So here is our meeting agenda. We've already recognized our meeting sponsor, and so now I'm going to turn it over to Tamara, who's going to give us a brief welcome.
Thanks, Kathy. So, well, welcome tonight. Thank you for joining. It gives me great personal and professional pleasure to introduce Dr. Sue Wong. Personal because we trained together at Georgetown, professional because she's just a phenomenal physician, scientist, community advocate, patient advocate, and hearing her talk is really inspiring. And we've been sort of trying to get her to our MAC for a couple of years now. So tonight's an important night for us. So if you don't know Sue Wong, she's an internal medicine physician and the medical director of viral hepatitis programs and the Center for Asian Health at St. Barnabas in New Jersey. She herself is living with hepatitis B and is the current president of the World Hepatitis Alliance, a non-governmental organization whose mission is to harness the power of people living with viral hepatitis to achieve its elimination. Her work with the World Hepatitis Alliance has focused on amplifying the voice of people living with hepatitis and the affected communities in order to achieve health equity on the road to hepatitis elimination. She's a mother of 4 children. She's very passionate about ending mother-to-child transmission of hepatitis B and serves on the Global Validation Advisory Committee, which supports the World Health Organization and countries in triple elimination efforts of HIV, syphilis, and hepatitis B. Dr. Wong has served as primary investigator for a number of viral hepatitis screening and linkage to care grants sponsored by the CDC and other funders. She's really led efforts locally, statewide, nationally, and internationally to end hepatitis. She's really a triple threat, phenomenal clinician, educator, and investigator. As I said, we trained together at Georgetown for residency. Her medical degree was from the University of Miami, and her master's of public health was from Johns Hopkins. And she did med peds actually when we were together at Georgetown, and has served as the on the Epidemic Intelligence Service for the Centers for Disease Control and Prevention. She's also served the U.S. Food and Drug Administration, and she was previously the director of hepatitis programs at the Charles B. Wang Community Health Center in New York City. So we have a true expert with us tonight, and I'm going to turn it over to Sue to talk about eliminating hepatitis.
Great, thanks, Tamara. It is extra special treat to be here with you. I was just thinking we started residency over 20 years ago, and
Yeah,
it feels so old. But I was really happy to be able to do this with you. And I think we've been on the stage a couple times now at ASLD, and last year we both gave like the debrief, so it was kind of fun to work together there too. And Tamara was always one of the smartest residents in our class, so you guys are really lucky to have her. And I feel honored to be here on the same stage as her. So now I guess I'm going to share my screen. So let's see if this works. Where is... Of course, when you need it to work, you can't find, where's my PowerPoint? All right, let me just share my actual screen because it's not working to share my, oh, here we go, share our windows.
We're all zoomed out, Sue.
I know. My 13-year-old always tells me I have way too many screens open, so I'm sure that's part of my problem. All right, so here we go. I'm going to talk about elimination of viral hepatitis, which we all know is just such an exciting concept, you know, just to think that this is where something that we can achieve in our lifetime. And so I'm going to go into some of the different aspects of it. And some of this might be a little bit different, I think, from the usual scientific content that we talk about viral hepatitis. But I think this is where I feel like it's been really interesting for me on my kind of personal journey as starting off as a physician, clinician, kind of working with underserved communities. I worked in New York City, which was in Chinatown, which is obviously heavily Asian, and started working with Hep B and just seeing a lot of the issues that underserved communities face. And then it's just been really neat to see, where all of our niches can really help strive for equity as we are on this journey to hepatitis elimination. And so that's opened my eyes to a lot of things and how important it is for patients and communities to be really involved. So when you look at the global burden of hepatitis and kind of where we are in the trajectory in its course, it really is alarming. We really are at a stage where if we don't do something about it, the projected statistics show that the deaths from viral hepatitis, which have now exceeded HIV, TB, or malaria, if we remain on the trajectory we are now, that by 2040, the deaths from hepatitis will actually exceed the three combined. So you can see right around 2014, hepatitis kind of intersected HIV and TB, and that kind of raised some headlines that we're not going the right direction. And the formal WHO director, Dr. Chan, said she summarized it very nicely, the world has ignored hepatitis at its peril. It is time to mobilize a global response to hepatitis. So it's striking that the majority of liver cancer in the world is still due to Hep B and Hep C, 80%. In the U.S., it's not as high as 80%. It's probably about 65%. But what we see as a trend, both domestically and internationally, is that liver cancer incidence continues to increase. Even in the U.S., almost by 45% just in the past decade and a half. And Hep B and Hep C are main contributors, although NAFLD and NASH are, of course, really an increasing cause as well. And what's just kind of a big gap is that the vast majority of people living with hepatitis are still remain unaware. And it is the fastest growing cancer-related death in the U.S. And in the world, it's like the third highest cause of cancer-related deaths. And in contrast, we are actually in the era of being able to eliminate viral hepatitis because we have the tools. We've got simple screening tests, many point of care tests that can be done in the community. We know what causes hepatitis, how it spreads, so we know how to prevent it. We have a vaccination for Hep B, still working on one for Hep C. We've got effective treatments for Hep B, and we have remarkable cure therapies for Hep C. So in 2016, the WHO adopted the goal of viral hepatitis elimination by 2030. So that means all 193 countries that are part of the WHO committed to this goal of viral hepatitis elimination. So in response, the U.S., we convened a committee for the national strategy by the National Academy of Science, and the conclusion was that we in the U.S. do have the tools to eliminate hepatitis, but it will require significant resource allocation, commitment, and strategy. So it really will not come automatically. We're going to have to put in some resources in order to happen. And this was chaired by Dr. Brian Strom, who's the chancellor at Rutgers. So all this to say, the status quo needs to change. We have all the tools. Obviously, they're not being applied the right way to the right population. So we need to have some innovations in order to change our trajectory. So, and what are the WHO targets? So basically by 2030, so what you see here, these were set in 2016. You see that the 2020 targets are kind of an easier target, 30% reduction, 10% in new infections, and then 10% reduction in deaths. And the report showed that we did reach those. But we have a much further way to go in order to get to 2030, because the end goal is to make a 90% reduction in new infections and 65% reduction in deaths. They did this year also add absolute targets too, which will actually make it more achievable for some countries, that some countries already have such low incidence that it would be very difficult, almost impossible to get to a 90% reduction because their population already had such a low incidence. So countries like Iceland, it would have been very difficult for them to achieve it by reduction, but by incidence, they'll be able to reach it. So where are we now on the road to elimination with just a decade left, less than a decade? WHO put out a report just May of this year, basically combining HIV, viral hepatitis, and STI as a global progress report. And this was an accountability for the GHSS, or the Global Health Sector Strategies, from 2016 to 2021. And 2016 is where they basically issued the call to elimination, and this is kind of the progress report. And you see that the deaths from, oops, something happened. The deaths from viral hepatitis B and C continue to be, so it's 1.1 million a year, which is, sorry, I'm trying to move this screen so I can see my slides. 1.1 million deaths a year, which comes out to one death every 30 seconds. And that's a stark number that we use in a lot of our communication, that one person dies every 30 seconds from hepatitis. And that's something I feel like if you want to grab the attention of the community, that is something that's easy to understand, as opposed to some of our other stats, which sometimes will go over people's heads. So this is the 2019 burden report on hepatitis. And for Hep B, it's just remarkable to me. I think we often don't understand like the sheer burden of hepatitis B, but 96 million people are living with hepatitis B. And that's just, it makes it the most common bloodborne chronic infection in the world. And you can see that the areas that are very heavily affected include Africa and the Western Pacific region, with a really large proportion of the Hep B infections, so 115 million. And also Southeast Asia. And while the Americas is looks green, like a low incidence, but what we've come to realize obviously is that there's a lot of immigration, and so the communities reflect the countries of origin. And so anywhere you have diverse communities and populations that come from other parts of the world, this is where you're going to find hepatitis B. So hold on. Oh my gosh, it's taking a life of its own. Okay, this is Hep C, our burden. So we're at 57.8 million. And if you know, that's a decrease actually from the last estimates, which were like 72 million. So it shows that we're making some progress with our DAAs, and we have reduced the incidence. But we find with the opioid crisis and injection use, there's a constant flow of new infections for hepatitis C, unfortunately. And in terms of the largest gap, really, when you look at all the different targets, still remains diagnosis and treatment. And we find that the large majority, as I mentioned, of people living with hepatitis are yet to be diagnosed. Globally, it's only 10% of people with Hep B and 20% with Hep C. And, gosh, sorry, my mouse is possessed tonight. 21% for Hep C, and then in terms of treatment, only 2% of people with Hep B are on any treatment, and for Hep C, only 13%. And you can see the stats vary by region in terms of the disparities. So these are the overall indicators that the GHS has put out in terms of targets that we're looking at, as I mentioned, from 2015 to 2020, 2030. We're doing well, as you can see, with childhood vaccination. baseline was already 84%, and we're trying to get to 90%, so that's not going to be hard. But really, as you kind of go down, you see it's really the testing and the treatments where we have the largest way to go. And what is it that countries can do when they are trying to prove that they've eliminated hepatitis? And this has come out actually very recently. The WHO issued a interim guidance for countries who want to submit for validation of having achieved public health elimination of all hepatitis as a public health threat. So they can choose a number of options. You can choose just Hep B, EMTCT, or prevention of mother-to-child transmission. You can choose just to eliminate Hep C, to say that you've eliminated Hep C as a public health problem, or option C, just Hep B as a public health problem. And then option D is to do it all, to show that you've eliminated both Hep B and Hep C as a public health problem. So they've now kind of put out what would a country would need to include in their dossier in order to be verified for this. And so we're now at the stage where there are a couple countries who will be kind of like piloting these targets to WHO. So at the same time, a lot's been happening. As I mentioned, the GHSS from 2016 to 2021 has finished. So now they are now actually going to reissue, and this was approved by the World Health Assembly in May, a new GHSS. And this strategy will go from 2022 to 2030. And what they've done now is actually really try to integrate HIV, viral hepatitis, and STIs with a lot of focus on primary health care, universal health coverage. UHC is a really big focus of WHO. And really leveraging health systems to have the most impact across all diseases. As you can see on the right here, equity, quality, innovation are all things that they want to see across all these directions in order to get to elimination or to end all of these diseases. So in terms of like kind of innovations that have gotten us to where we are, obviously we know with the DAAs, it's just been remarkable watching what's happened, how we have so many regimens now and many 3 pan-genotypic options where people can be cured in as short as 8 to 12 weeks. And I just love this line in terms of talking about how we're getting to Perfective here. We're at 95+% cure rates for Hep C, and I just think that's so amazing. And so that's really taken us a far way and really will be pivotal to getting us to eliminate Hep C. So where we are, this is a recent kind of report card for the world. This is put out by the Center for Disease Analysis Foundation. This is a website that's available for anybody. It's called Polaris. If you go on the website, you can look at any country and look at how they're doing with their absolute impact and programmatic targets. They've really coalesced some really amazing information. And you can see, there's a handful of countries, the green ones, that are on track for eliminating Hep C. Australia is one of them, Egypt. We've got France, England, and Spain. In Canada, you see the U.S. is not on target for 2030. And the recent article I saw had us projected to reach it around 2037, with different states reaching it at different times. So some of the leading countries of innovation, I'm sure many of you have heard at all the liver meetings. Australia is one of them. One of the big things that they did was really decentralize and task shift. And you see over time from 2016 on, they really started to shift the Hep C treatment more towards GPs. So that's where the purple bar is, and less on gastroenterologist and infectious disease physician. And there were a lot of training programs built into their national campaigns. And I just remember hearing even one of the gastroenterologists saying, they would actually reject patients and send them back to the PCP if they could tell it was like a very simple case and, somebody not cirrhotic. So there's a lot of, I think, collaborating between the specialists and the primary care doctors. And I think that's something that we, need to aim for as well in the U.S. to get to this in order to increase access to the population. So Egypt obviously is a real leader. The country has led the way in committing to eliminating hepatitis. They've screened 50 million people and treated almost 5 million people. I mean, it's remarkable what they've been able to do. It's completely free, and they basically mobilized. You see the vans, and they utilized cell phones and text messages, and people could register online to get appointments and So you see immediately when this happened, there was a surge of people been waiting for treatment who were able to get treated right away. And now it's trickled down, and there's obviously a higher number of people that have to be screened in order to get cured. But they're also leading the way in Africa and have committed to treating 1 million people a year in the rest of Africa. So this is what you see that can be done if a country really gets behind it. And in the U.S., we are fortunate. We were happy this year. Joe Biden put out a statement on May 19th during National Hepatitis Testing Day that the U.S. is committed to eliminating hepatitis C. We didn't see additional money come in, but at least there was an announcement. So I think there's a lot of work we can continue to do in advocacy to make sure the resources follow those statements. And this came from HHS, kind of their report on acute viral hepatitis cases. We recently had seen a number of epidemics happen with Hep A, and so vaccination is really important and often doesn't really get covered, and a lot of talk about hepatitis elimination. Hep B, you see this kind of constant source, a constant incidence of acute cases because of the opioid epidemic. And then acute Hep C has continued to rise because of the opioid epidemic as well. So we know in 2020, the CDC pivoted and updated their guidelines. And it is now basically, we went from cohort screening of Hep C to now all adults should be screened at least once. Every pregnant woman, every pregnancy, and everybody with risk factors should be screened regularly. And it's that bimodal trend, which has really driven that change in policy. And I think you're probably seeing in every state. I just popped up the New Jersey opioid dashboard where you can see the exact same bimodal trend that you see nationally, where you're really seeing the 20 and 30-year-olds with this increase in Hep C infections. We're seeing it at our own hospital as we're doing kind of automated testing in our hospital, inpatient and ED. About half of the cases we're seeing are actually outside of the baby boomer range. So a lot of the professional organizations are getting on board. ASLD in 2019 put out a call to action towards Hep C elimination, really focusing on simplified approaches to Hep C testing and cure, and also decentralization. And this was great to see all the liver societies get on board, ALE, EASL, APASL, and this was led by the Clinton Health Access Initiative. And so this is something we want to continue to challenge and, call to accountability, these liver societies to continue to push for that, because the decentralization thing does take support, and it's not automatic. I think as I'm a primary care physician, I've started treating Hep C. I don't see a lot of other people doing it except in certain pockets, and so I think we do need to do more in terms of raising up primary care doctors who can do it. So yes, we definitely have to evolve our model of care, and every step of the way. So with testing, we got to improve access to testing, improve awareness and education, prompts, a lot of automated prompts. I think probably a number of you are working in facilities that might have focus grants that are doing automated screening. There's linkage to care. Obviously, we need a lot more providers. Obviously, I think there are a lot of great specialists around, but not everybody has access to GI and hepatologists, and the ECHO program has done a great job expanding that. But we really need to embed it into primary care as well. So co-localized testing and treatment facilities has been talked about a lot, especially in places that are providing substance abuse treatment. Treatment uptake is something we have to focus on, and making sure that we're able to not just have it available, that people actually that there's uptake with it, and especially in people with complex backgrounds, and treatment adherence. So providing support for that. So instead of us really expecting patients to come to us and the kind of more specialized services, we really want to get to the point where we're able to bring Hep C care more to the communities. And it may look very different from a hospital or a tertiary care center, maybe more like community outreach, mobile units like they did in Egypt, or even shelters. So we're going from the centralized traditional approach to a more decentralized approach, where we may be doing co-localized care in places that are providing STI care, the syringe exchange, even prisons and community health centers. So also something that came out new that's innovative is WHO came out with self-testing guidelines. It just came out in July 2021, saying that self-testing can reach people with Hep C who don't otherwise test using existing and may prefer self-care options. And so this will be really great to see if it picks up. There's obviously, we're sure we've had point of care tests for quite a while, but they've been mostly done in communities administered to people, not people being able to do this themselves. So I'm going to shift over to Hep B a little bit. We saw CDC expand screening to universal, which is what HIV did a number of years ago in 2006. Hep B is still the one infectious disease that's still kind of risk-based. And what you see here is like when you rely on risk-based testing, I'll be the first to say as physicians, we don't do a great job of assessing risk sometimes. We often, we all know we have implicit bias. We may not want to, we may not have time to ask our patients, or patients may not tell us the truth. And so because of that, we are not always screening the right people. And so as a result, with Hep B, we said the large majority of people, 990,000 out of 1.2 million, which is a low estimate, of people with Hep B are unaware and not in care. And only, about a quarter are actually aware, and a lot are not in care. And only a small sliver of people are actually aware and in care. So, this is how complex the screening recommendations are for Hep B. It's a lot of people. I'm just thinking you have to remember, which countries are considered endemic. Certain populations, IBDU, men who have sex with men, people who are on immunosuppressive therapy. And at some point we did kind of a calculation of what percentage of the population this would be. And it came out to like 75 or 80% of people who might, at some point in time fall into one of these categories. And so at this point, we know CDC is actually considering universal screening recommendations. They are meeting potentially to put out recommendations this fall about universal vaccination in adults in the US, and they're hoping alongside with that to be able to put out recommendations also for universal screening, because obviously if we're trying to get to elimination, we're going to have to do a better job at identifying people. And if we do it right, hopefully after 2030, we won't need to be doing these things, and we can move on to the next infection. This was a good article that came out recently, kind of saying that it is cost effective to do a one-time universal screen for Hep B for all adults in the US, and that you would actually save $263,000 per $100,000 per 100,000 adults screened, because obviously you would save on, you would be able to prevent cirrhosis, HCC, and liver transplants. So let's, I think this is convincing, hopefully, for policymakers and insurance companies that it's worth it in the long run to screen people. The other thing about Hep B, besides the screening, is also the guidelines that we have, the recommendations we have for care and treatment, and looking at our amazing guidelines that we have with ASLD actually being followed. And unfortunately, we're seeing there are quite a number of gaps where people who are in integrated healthcare systems with Hep B, and this was the Czech study by CDC, we found that that a lot of people were not being followed. So these are people who had diagnosis codes of hepatitis B. It looked like the large majority of them were getting lab tests. More than about 80% had at least one ALT done. But only less than only 37% had actually had one viral load done per year of follow-up, and almost 20% had never had a viral load done. A third of these had actually been prescribed antiviral therapy, so we think that they did have decent, active hepatitis. And even among the cirrhotics, only 50% had a viral load done. A fair amount had never had a viral load done, and quite a number had were not getting annual imaging, only 27%. So we know there are a lot of gaps in our care, and so really the more simple we make it, the more we're going to be able to give patients access to services if it's easier to follow. So when you look at our guidelines, there are multiple guidelines around the world, and they vary based on e antigen positive, e antigen negative, the viral load being 2,000 or over 20,000. And it just is incredibly complicated. It also requires patients that are regularly following in with you every 3 months, every 6 months. And we know so many patients just disappear for a couple of years, right? And they may feel safe. Oh, it was less than 2,000. I feel fine, and they may not come back for a couple of years. And unfortunately, we've had too many cases of patients who dropped out of care for 5 years, came back with a large hepatoma that was unresectable. And this is really what we're trying to avoid. So the more we can simplify our algorithms, and I try to tell the primary care providers, it's like how you check hemoglobin A1C, you know. At this point, I find diabetes way harder to treat, way more complex to treat than I do Hep B. So many more medications that are available, and with Hep B, there's only 3 really oral ones. And so I think it's time for us to shift and at least empower primary care physicians to provide monitoring, you know, for their patients. And for many cases, it's, you know, maybe 80% of cases, you know, will be solidly inactive carriers or obvious people that need to be referred, but there's at least a large majority of people, I think, who could be monitored in a primary care setting. We're in an exciting time for Hep B as well. A lot of therapies in development, in preclinical and early stage development phase. And this is a little bit late. This is not most current since we know TAF is on the market now, and Merclodex has been approved. But there's a lot going on. There's a lot of excitement. And one of the big things that my work has been really to do is to really advocate that the patient perspective should be really incorporated closely on our road to cure, and that patients should be involved in this process. And I think we did a good job with it with Hep C. And for Hep B, why people would say, well, what is it that having patient involvement would do? Well, it would help clarify, the rationale for finding a cure. Why does the cure matter to patients? To understand if proposed treatment interventions would be actually useful. Is the cure I'm proposing actually going to be practical in the real world? To avoid any unintentional harm to the affected community by exacerbating stigma, possibly, and to maintain a trusting and respectful relationship between the scientific community and the affected communities. And so really, having trials that are more patient-centric means that we involve patients early in design and execution. That means early on we design our studies to actually have relevance to patients, that the outcomes we're looking at are actually the outcomes that are meaningful to patients. And this actually helps encourage participation in clinical trials. And this potentially having patient input could impact your inclusion and exclusion criteria, your visit burdens in a trial. Do patients really have to come in? Are there things that they can do remotely to still remain in a trial? And like I said, patient relevant outcomes. And some of the studies that have been done in patient-centric trials have shown that that these trials are actually much more likely to produce drugs at launch, 87% versus standard trials of 68%. And they were actually able to enroll patients much quicker than the average trial. So I think this is something, I think with all drugs is an area that we should, expand in. So, and in terms of like looking at what matters to patients or what is it that's living, when we look at, as a doctor, when we look at patients with Hep B, mostly we're very focused on the biochemical things, their lab results, the viral load, their symptomatology, but there's so much underneath that is not measured in the clinical setting and yet so greatly impacts their lives. Just the impact of living with Hep B, which is actually psychosocial, and we haven't figured out how to quite measure this. And it could be primary impact, the fear of the disease progressing, fear of infecting others. There are secondary impacts, and that could be stigma and discrimination that they feel from the community or even healthcare providers or institutions, such as schools or governments, if they have to show their test results, if they have to get tested in order to get a visa. And then tertiary impacts where there's some self-stigma, and people begin to withdraw from society and feel isolated. So I work closely with the Hep B Foundation too. They have a international kind of global consult line, and they get consults every year, so from people all over the world. And you hear these heartbreaking stories of people who are living with Hep B, and it just really devastates their lives. We don't often hear these. I think even as a doctor, my patients don't come to me saying these things. And I think these are happening around the world. So you hear, you see these stories of people who are facing a lot of stigma, even from healthcare providers. This one patient said, my GI doctor said to me, you should have known better, when I shared how I contracted Hep B. And then, people talk about how they feel like they're going to be discriminated against, and that they don't have hope for their lives. A lot of young people feeling like they don't know what this means for their future in terms of future relationships or education or jobs. And the stigma is something that really does, impact a lot when we talk about just the burden of disease, and this is not often measured. And so the WHO, we did a civil society survey, and there's many variations of how stigma can impact somebody's life. So large majority of these people who have responded to this had said that 72% of people do experience self-stigma living with Hep B or Hep C. 50% were experiencing social exclusion. It can even impact loss of job or income. 42% people were reporting that it impacted their getting a job. And there's also healthcare stigma. 37% reported feeling some level of abandonment by their spouse or their family members. You hear stories of people getting divorced or disowned by family members or their in-laws because of their hepatitis B, or being forced to have an abortion because the mom was found to have Hep B while pregnant. And it's pretty devastating to hear, stories like that. So even in the U.S., we are still getting a lot of cases of healthcare worker discrimination because, we have to get tested to work at a hospital. And not that long ago, there were 2 med students actually in New Jersey who lost acceptances over their Hep B diagnosis, and the DOJ was brought in. They had to file a case, and they did eventually settle over these 2 students, but they were, they lost a year of their lives. They'd already put in their they already paid for a year lease, and they basically were out. They were not allowed to enroll in school when they found out during their employee health visit that they'd had hepatitis B, and the letter actually said you are a threat to yourself and to others, and they weren't allowed to matriculate. And since then, one of them has gone on to, they did some research and is now actually pursuing medicine at a different school. But it's very traumatic, what's happened to these students. And we're now at the point where thankfully, this is now considered, Hep B is now protected under the American Disabilities Act. And there was a letter sent out from DOJ to all the healthcare schools that they were not allowed to discriminate. And this was actually refreshed last year. DHHS sent out another letter. So, but in spite of all this, the Hep B Foundation continues to get 20 to 30 cases a year of students or professionals, and some of them are nurses, physicians, x-ray techs, dentists who are facing discrimination. And if you hear of any such cases, because a lot of times they are supposed to be, there's supposed to be an expert panel that reviews these cases. But if you hear of such cases, the DOJ is actively open to getting reports and having complaints filed. So there's a lot more awareness now for Hep B. I do think in the past couple of years, it's been amazing to see hepatitis on the mainstream media and focused on patients. So in this Nature article, it was focused on Africa and hepatitis, and they feature a number of stories from patients. I did an interview for Science, and they were more interested that I was a patient than a doctor, and so they ended up taking that angle of the story. And so it's, I think the visibility has been really helpful. So, and I'm just going to talk about vaccination because this is near and dear to my heart. These are my 4 kids, and I really attribute them not having Hep B, obviously, to them getting the vaccine after they were born. And so the birth dose is just a really critical part of us truly eliminating Hep B around the world. And also just want to make sure everybody knows that we've got the 2-dose Hepatitis App, which has been approved for a number of years now. We have it in our office now. For a while, my office manager would not order it because it was so much more expensive, but now the prices have come down. So we have it in our office, and it's 2 doses. Patients are done in a month, so the completion rates are much higher. And for those who are non-responders, it's more immunogenic, so that's great too. So sadly, we still have an estimated 6 million kids under the age of 5 with Hep B. And this really shouldn't be the case because we've had the birth dose for decades and it's been recommended. But you can see in certain areas, especially Africa, the birth dose is not yet available to a lot of babies. And so worldwide, only 40% of babies born are actually getting the birth dose. And it's been recommended by the WHO for a number of years for them to be receiving it under 24 before 24 hours after birth. And it's very inexpensive. It's 20 cents. It's just nobody's paying for it. The countries aren't paying for it. The international funders are not paying for it. The Gates Foundation is not paying for it. Gavi, the global vaccine group, has said they will pay for it, but because of COVID, it's delayed. And so we're really advocating that they act quickly on that, because while we wait, more kids are getting infected. And in the U.S., we see 800 to 1,000 infants a year are still getting infected. I think we do a decent job. Almost, they say 95% of moms during pregnancy are getting tested. But not all of them are getting viral loads done. And those who have high viral loads, over 200,000 who should be treated, are not always getting access to care. So we do have gaps even in this country. And even the birth dose, only 69% of babies in the US are actually getting a birth dose. So we have to work more on hospital policies, and even with pediatricians, making sure that they're supportive of getting the birth dose in the hospital, not waiting until they are discharged and at the pediatrician's office, because there often is a gap where the pediatrician who sees the baby a week after doesn't realize the baby didn't get the birth dose in the hospital. So it gets missed. And those who get infected early on are the ones who develop chronic infection, as we know. So this is just showing where a lot of the gaps are. It's in some countries, the birth dose is only given for infants born to surface antigen positive mothers, but the recommendation is really that it's universally given, similar to vitamin K is given to all infants at birth, erythromycin, the eye ointment is given to all infants at birth. So I think there's good reason to include it for all. So just some other stories of women living with Hep B that face a lot of discrimination, intimate partner violence, and a lot of them really confused about what their babies need. So on the right side, some of the doctors are telling moms that the babies should get a pentavalent vaccine, which is not the same as getting the birth dose, but there's not access to the single birth dose in some places too. So information is not readily available sometimes too. So this is a model that was published this year about what the impact of COVID is on Hep B, PMTCT. And we think that because there's been a delay even in infants getting birth dose, because there's less hospital births, we're worried that there may be a projected additional 5 million babies with chronic hepatitis who are born in this decade. And out of those, potentially 1 million additional deaths. So we really need to accelerate access. So at the Alliance, we put out this No Hep Moms campaign, really trying to advocate for more access and really pushing Gavi. We actually put an open letter to Gavi urging them to accelerate their plans to start administering the birth dose. Covering the birth dose for countries that don't already have it. And we've created, a bunch of resources that people can use in social media. And this is, something that we hope other physicians can also be a part of as well. This is also this is a WHO survey looking at impact of COVID on disruption of services. Compared to HIV, you see here the red bar is much higher in Hep B and Hep C. So more countries reported a higher disruption, more than 50% disruption of services for both treatment and diagnosis of Hep B and Hep C. There's also, if you see in the gray area, a large percentage that just didn't know. And I think we know that HIV has a lot of resources. Hep B does not. Hep B and Hep C programs are often dovetailed into other programs. And so we may not even know the true impact of the disruption because of that. This was a study looking at the decrease in the number of DAAs utilized around the world during the pandemic. And you see in March, there was a steady drop. And we're not quite back up to our numbers before. So that's also concerning. And then this is just another model done by CDA, also just looking at excessive deaths. We think there may be an excess of 72,000 deaths or an excess HCC because of these delays that we're seeing with COVID. So then finally, I just want to close with talking about the work of the World Hepatitis Alliance. We're really focused on making sure that people who are affected by viral hepatitis are actually included in the elimination efforts. We believe that unless we include people who are affected, we're not going to be able to get to elimination, and definitely not equitably. what I often tell people is, while we don't have a lot of money in hepatitis, we definitely have a lot of people. So if we can activate the people living with hepatitis and energize them, they are actually a force. I mean, we've seen this done with HIV, which affects far fewer people, 38 million, compared to 50 million people with Hep B or Hep C, and they can actually help drive awareness, demand access, drive that advocacy, make it personal, help combat stigma, improve program delivery. And really, what I think is the great intersection is partnering with scientists and researchers and policymakers and physicians like you all. And I just love this quote. We had a campaign called Find the Missing Millions to try to diagnose people. And we talked about the importance of involving civil society. And I just love the paragraph that we had here. People living with viral hepatitis and the affected communities should be at the heart of every effort to eliminate viral hepatitis. Aside from fulfilling the need for trusted entities that consistently disseminate reliable information, which we know is an issue even with COVID information, civil society organizations bring fundamentally important perspectives and experiences which greatly enhance the effectiveness of strategies and programs. So this year we launched Hep Can't Wait. You probably have seen it on social media. There's a lot of resources out there to spread the word. We did a social activation where people pointed to time. Tamara was part of this. And we did a big campaign amongst ASLD, getting people to point to the time and say, you know what, Hep can't wait. Like, we have 9 years left. We really need to catch up because of COVID. We had some really amazing things that members did around the world, kind of on World Hepatitis Day, lighting up monuments, and we even had fire eaters in North Macedonia. And this stuff really makes a difference because then people around the world kind of notice. They notice things that hepatitis is, maybe something important. And in the U.S., we had a sign on the Times Square also. All right, and I'm just going to close with, we have a campaign that called No Hep, which is, we have a special one just for medical visionaries. I hope you will all join if you can get on the No Hep website and sign up. We think medical physicians, providers, researchers really are an important part of leading the way. You all are advocates for your patients. You hear their stories, you know what they struggle with. And I think it's a combination of providers and patients working together that really will drive change and make the world take notice and really get the resources that we need to get to hepatitis elimination. So the ASLD leadership getting behind No Hep as well. So we hope you all can join us as well as we move forward, and glad to be here with the ALF. Thank you for having me. Back to you, Tamara.
Thank you so much, Sue, for a fantastic talk. I mean, talk about a whirlwind. I was talking to people about sort of public policy and what happens in the stewardship of a human life along their sort of course of self-care, right? So when we're little, our parents sort of lovingly care for our vaccination records, and somehow or other, when we shift to adulthood, all of that goes out the window, right? And I'm just trying to figure out whether there's a way. I mean, obviously in the present climate with misinformation and anti-vaxxers, we have a big fight, right? But in general, for those people who really do care about preventive health and making sure their children are vaccinated and that their school records are right and, that kind of thing, why can't we teach adolescents as they go into adulthood that these things are important for themselves, right? So that if it just seems like we forget about adults. And I think a lot of hepatitis B in adulthood is completely forgotten. People, end up getting diagnosed with a massive tumor. They never knew they had hepatitis B. It happens all the time. And I just think we're missing adults. And I'm wondering whether the dialogue in children, which obviously we're not anywhere near where we need to be, at least can we extrapolate from some of that to teach adults about preventive medicine, the worth of testing and vaccination? And is there any parallel that you can draw between those two populations to maybe increase awareness in adult populations? Yeah, I think, with COVID and this all misinformation thing, I
definitely thought, we need to do a better job of just teaching health in general, right? Like just people understanding and not making it that, I think we all see this, right? Your patients never keep their own records. They hop around doctors. They expect us to all know what's happened beforehand. There's a sense of like, oh, the healthcare system should know better. And somehow we're all connected, even though we're clearly not. And so, it's a challenge to really, have people take ownership of their health the whole way, like you're saying, right? Like somehow the shift between peds and adulthood is not done well, right? In terms of healthcare and preventative medicine, right? A lot of times people don't come until it's too late. I think some people are muted, so I think maybe they have some other insight too.
Sue, that was a great talk. As you know, we kind of both had focus grants, and we've run similar projects with automating testing. I think there's a world view, there's a national view, there's a state view, and then there's your local view. And I think one of the things that I would love, like the American Liver Foundation, is we really don't use technology to help us find people who need to be tested. And that's really low-lying fruit. In terms of like some of the things we can advocate for, like we have all these EHR systems that when you look at how they collect data, it's a mishmash of, poorly organized data. I mean, it seems organized, but it's really not when you try to extract data for, for various things, particularly hepatitis. And it would be nice that if we got some support, I mean, when you're in a liver, as a former liver transplant center, if you're at Columbia, you're at Mount Sinai, NYU, Monty, transplant is very profitable. There's a lot of emphasis on liver disease. But when you're in a non-transplant center, a very different creature, and you have the hospitals don't make money on treating hepatitis B and C. They just don't. And that's really a big challenge, is convincing your admin to run a program to improve diagnosis of Hep B and C. I mean, if we didn't get these focus grants, these projects would have never, ever been initiated, because nobody's going to, spend the money to have IT to do these, algorithmic upgrades.
Yeah.
It would be really nice if we got some backing from like the ALF or some of these organizations to advocate, like, we have the technology to do this. This is not rocket science-y. I always make the joke is when you look at the computer power in a Nintendo or PSP 2 or 3 or 4 or 5, whatever level they are now, they're using their technology far better than we're using them in our hospitals. And our job is far more serious. So I don't know, that's just my 2 cents. I think I would love for ASLD, American Liver Foundation, to really make a statement of how we can, use in our country. Like, we can't advocate for Africa because we're not in Africa, but we can advocate for our country and what our infrastructure supports and some of the things that we can do, which really wouldn't cost that whole lot in the big scheme of things to implement.
Yeah. So, I think what I've learned is like really being able to tag Hep B and Hep C onto other initiatives that the hospital is doing. So for us, like, Andrew did an amazing job when he was at St. Joe's in doing the automated screening for people with country of origin for that was endemic for Hep B. And I basically copied what he did at St. Barnabas. So, I think collegiality is great. Andrew, I owe a lot of our success to, you sharing your ideas. But our hospital was like so amazed once we did it. We were able to say, did you know that you had so many Haitians coming to the ED? Because you never track that. You only look at like if they're Black, white, or Hispanic. You didn't know that there were so many Haitians or people from Ghana, like in our community. So the people who do diversity and like community needs assessment, they love that stuff. They're like, wow, we're actually serving the community. So it's checked that box off for the hospital. And I think the more you can leverage kind of hepatitis into those kind of, maternal child health and social justice, the more you can get hospitals behind it. I do think we need to advocate more for quality measures, because that's what makes EMRs change. That's what makes the hospital, the payment models for like quality. So we need to get Hep B and Hep C into the like NQF measures too.
No, because Hep C, is one of those core quality measures by CMS. I haven't checked in the last year or so, but Hep C testing, ultrasonography for cirrhotics is the CMS core quality measure. These are all things that hospitals get points for doing, but they just need to be educated that, well, you're going to get better payment if you do that. And one of the things, on the flip side of that is, as a surgeon, my admins want me to do liver resections. I do them laparoscopically. It's very nice. They have short length of stay and it's all good. But, you have to like, as a transplant program, it's a no-brainer because they make a ton of money. Admins love that. As a non-transplant center, it's more of a challenge. I mean, and that's just the reality of how our healthcare system runs today. It's really about what revenue you're going to generate for your hospital. So we need to be creative and letting them know, well, listen, if you find 1,000 hepatitis C patients with them B, 30% are going to have cirrhosis. You're going to get a lot of ultrasounds. You're going to get a lot of MRIs, and you're going to generate revenue. And you're going to get some early lesions, and you're going to get some resections, and you're going to do some Y90s, and you're going to do all that. And it all comes down the line. So we need to be a little more cognizant of how we can sell these programs to show hospitals there's revenue, because that's really what they care about. I mean, at the end of the day. So it's just something, I'm sure I know Barnabas and Livingston, they're all about the revenue. So, and I'm sure they're seeing some downstream revenue by some of the things you do. It's a kind of a topic nobody wants to talk about, but it's the reality of the environment we work in.
Yeah, totally agree.
Sue, I think this was a wonderful presentation. If I could just chime in on a few things. I still believe that one of the issues that we're dealing with is a shift in attention in hepatology to non-viral hepatitis-related diseases, particularly NAFLD and NASH. I can tell you in my own practice, literally every other question that I'm being asked by patients is, I have fat on my liver, I'm worried about my liver, and of course, with the increasing attention now in many healthcare systems on obesity management, surgical and medical and otherwise, there is a paradigm shift here away from viral hepatitis. Almost like there's an assumption that viral hepatitis is a thing of the past. And it's lectures like what you just gave tonight that is kind of redirecting this attention that, hey, we're not yet done with viral hepatitis and that we need to pay more attention to it. I just think it's something that we need to constantly refocus and redirect attention where appropriate to the subject. So I think it's important that we recognize this change in interest in other diseases.
Yeah, no, I mean, I felt like we could see that even in, going to the liver meeting, the last time it was in person, how I felt like after the DAAs were done, it was like, time to move on to fatty liver. And there were very few sessions that were focused on viral hepatitis. And, vaccination never makes it. I mean, Hep A is never discussed, and I think the things that are like really the things that have the biggest impact on the population, don't make it to the scientific stage, unfortunately.
Yeah, but one could argue, George, that a lot of NAFLD is also tied up in prevention. I mean, I think our incentives and our planning and the way we deliver healthcare is just, I mean, you basically are dealing with a very sick population for a reason. It's that the entire focus of the healthcare system is on illness and prevention, which is really unfortunate. And I think that, there's clearly a lot of money in healthcare and insurance and all of this, but if you want a healthy population and a productive population, then, leaders around the world have to take a stand and say, we're not going to use this as a moneymaker, but more as a, how are we going to increase our productivity as a nation through health, right? If you think about just the degree of illness that Americans have, it's staggering, right? So I think that, all of this, I think if we could really think about prevention, because clearly, I mean, so much of what we see in HCC is vaccine preventable. I mean, it's just devastating. So I think, you know, that's really where we have to go to policymakers and really fight a global fight to change the way we deliver healthcare. You know, and I think, you know, the VA is a really good example. You know, we treated 140,000 people with their hepatitis C in just a matter of a couple of years because the whole system pivoted to do it. It's doable, you know.
I think, George, one of the things that's that we do is we check FIB4s on everybody. So it's part of your Chem 12. So it's everybody gets a FIB4, and you know, it's obviously not perfect. Your alcoholic hepatitis will go off the roof, but it'll come back down to reality. But what it does, it raises awareness amongst the primary cares and the family medicine. And you know, we held a bunch of educational centers. So in Hudson County, in our system, in the 3 hospitals, they get universal FIB4 reporting on their Chem 12, and we get a lot of people. And we see a lot of people with liver problems. And then once they reach that, you know, they have a FIB4 of 3 point whatever, then you know you're gonna ask the medical intern or resident, they just send a Hep C and B, and what's their BMI, what's their hemoglobin A1C, and then it initiates the discussion. But if it's not out there, there's no discussion. So I think it's a very simple thing to do for any healthcare institution. Just put a FIB, you know, you can use APRI score, FIB4, but the thing is, the beauty of it is, you know, you don't need any, we get so many Chem 12s on people and CBCs that it just, you know, it's gonna give you a small alert that something's not right. And you know, in Hudson County, NASH is just out of control. We just have out of control NASH in Hudson County. So we send a lot of referrals to our bariatric medicine people and our gastrics or our bypass people. And now, but something you can, you know, depending on where you are, it's really easy to, you know, it's really easy to do.
Well, thank you, Sue, and thanks for everyone's input. I mean, I think, you know, Sue, I will go check out No Hep. So thanks for sharing that with us, and thanks for everything you do. You're really an inspiration.
Thanks. Yeah, I'm glad to be here. And I mean, all of you guys, just the fact that you're here, I think are, you know, advocates in a lot of the work that you do. So I think, you know, there's a lot of collaboration we can continue to do and sharing of ideas. And yeah, Andrew, your idea of the FIB4 would be great, you know, to adapt to more places.
Yeah.
Thanks.
Thank you so much, Dr. Wang. I just want to, before we wrap up, I wanted to mention to our MAC members that we do have 2 additional fall meeting dates coming up on October 28th and December 7th. And the topics of those educational presentations on October 28th will be New Frontiers for Fatty Liver Disease. Dr. Bubu Benini from Yale will be giving us an update on clinical trials and drug approval status. And on December 7th, Dr. Glenn Morgan from Hartford Hospital's Liver Center will be talking about transplantation. So you will receive calendar invitations for those, and I do hope that you are able to join us. We also have, just a reminder, our liver health poster competition going on. The website is shown up there. I invite you between now and the next week or two to visit the website, take a look at the posters. I believe there's somewhere between 25 and 30 posters from across the country. You will have the opportunity to support the American Liver Foundation and vote for your favorite poster. So while the website is up between now and the middle of October, please take a minute to take a look at some of those posters. And just a reminder, the American Liver Foundation's gala is coming up. I'm not sure why that date is wrong, but it's actually October 21st. And it will be held in person in New York City at the Gotham Hall. So we hope to see many of you there. And And then certainly in closing, I would just say, you know, stay connected to the American Liver Foundation on social media. This is a, you know, snapshot of how you can connect with us and stay connected. And again, in closing, I wish to thank Dr. Wang. I know that she is highly sought after speaker and very busy mom of 4. So we thank you so much for being with us tonight, and certainly thank you, Andy and the Gilead team for supporting this this medical education program. Tamara, I'm going to turn it over to you for our final comments of the night.
Well, thanks everybody for joining. You know, I think this was a phenomenal talk. We've been sort of apart from each other for a while, not having met over the summertime. So thanks very much to Dr. Wong for really getting us back together and on track academically for the new year. And we look forward to the talks coming up. And thank you all for joining this evening.
Wonderful.
Thanks. Thanks,
everyone.
Tamara. Thanks for having me.
Thank you.
Good night, everyone.
Bye. Take care.
Good night.